There's really three crucial questions in understanding the role of inflammation in cardiovascular disease. The first question is there evidence that people who are healthy, who have elevated levels of inflammatory biomarkers like C-reactive protein, are at increased risk even if other risk factors are normal? The answer is overwhelmingly yes. Meta-analyses of over 50 studies tell us that if your CRP is high, you are at increased risk of a heart attack, stroke, or cardiovascular death. That's no longer controversial. The second question, the one I think is the most important question, is if you identify someone at increased risk because they have inflammation, would you give them a therapy they otherwise would not have received? And would that therapy reduce their rate of heart attack and stroke? I'm a physician who does not measure any novel biomarker if it will not change my practice. Well, the Jupiter trial answered that question. Remember, Jupiter enrolled patients who would never receive a statin under any guideline because their LDL cholesterol was already below the treatment target in primary prevention. But they all had an elevated level of C-reactive protein greater than 2 milligram per liter, and we saw a 55% reduction in heart attack, a 48% reduction in stroke, a 47% reduction in angioplasty bypass surgery, and a 20% reduction in all-cause mortality. So we know the answer to the second question. If a patient is at increased risk because they have a CRP, they have a therapy you should give them they otherwise would not have received, and that's a statin. But statins are very powerful drugs for lowering LDL cholesterol, and they're very good drugs for lowering inflammation. So statin trials cannot answer for us the key issue, which is the third question, which is, do we have evidence that lowering inflammation directly will lower rates of recurrent heart attack and stroke? Well, it's very exciting for us because we have just launched 2 different randomized trials directly asking, if we lower inflammation, can we lower risk? The first is a collaboration we're doing with Novartis using a very interesting drug, canakinumab. This is a novel interleukin-1 beta inhibitor. Interleukin-1 is a very important part of the IL-1 to IL-6 cascade. The drug we're using, canakinumab, is already approved in Europe and the United States for the treatment of some very rare disorders of childhood that have high levels of interleukin-1. And we have shown that when you give this drug, I can lower CRP, I can lower interleukin-6. The question is, if I give the drug, can I lower rates of heart attack and stroke? So we've designed a clinical trial called CANTOS, the canakinumab anti-inflammatory thrombosis outcome study, that I have the honor of being the principal investigator of, which will ultimately enroll 17,000 patients around the world who've had a prior myocardial infarction. They're already on a statin. They still have a CRP that's greater than 2, so they have this pro-inflammatory response, and they'll get 1 of 3 different doses of canakinumab or placebo, and we'll see whether or not we can reduce cardiovascular event rates and rates of diabetes. That trial already has more than 3,000 patients randomized, so it's already up and running. The second study, which we just announced at these meetings, is funded by the United States National Heart, Lung, and Blood Institute, which is using low-dose methotrexate. This is the same dose of methotrexate that our patients with rheumatoid arthritis routinely take as their primary treatment. We know the side effect profile. Interestingly, patients with rheumatoid arthritis who get methotrexate have lower rates of heart attack and stroke, but that's observational data. So the NIH has asked us to do a clinical trial called CIRT, or the Cardiovascular Inflammation Reduction Trial. Again, post-myocardial infarction patients who have a pro-inflammatory response as defined by either diabetes or metabolic syndrome. Half will get low-dose methotrexate, half will get placebo. Again, everyone already on a statin. And this gives us 2 swings at the bat, so to speak, to see whether or not reducing inflammation can directly lower risk. So to summarize, we already know that inflammation and CRP screening is a very effective tool for identifying the many patients who have heart attack and stroke we miss with regular screening. We already know we can give these patients a drug they otherwise would not have received. That's the statins from Jupiter. Now the question is, can we target inflammation per se? And as a principal investigator of both of these trials, we're very excited because we finally have enough evidence to have both the pharmaceutical industry and the National Institute of Health interested in this fundamental biologic question and try to bring full circle the idea of what's the role of inflammation in heart disease, and can we actually use it to better the lives of our patients.